Welcome back to the PFC podcast. The views and opinions you are about to hear are the speakers and do not necessarily reflect those of anyone else. Now on to the podcast.
Welcome back to the PFC podcast. And today I am with Bryce, and we are going to talk about training non-medics. Why do I even bother? Right?
Glad to be here, Dennis.
Hey, if you would, just a real quick basic intro of yourself.
Cool. So my name is Bryce, and I'm a 18 Delta out of 10 Special Forces Group.
Very good. What I'd like to get into is, I know how freaking hard it is to try and get these guys to do anything medical, right? That doesn't involve IVs or talk about putting fingers in different places, right? So why do I even bother with this?
Well, I've been really lucky because my guys are very interested in medical training. And I had a senior that really drove it home with the team when we were prepping for some deployments. So it kind of became a part of our team culture on the front end. But generally, when I'm talking to other guys, one of the things I like to hammer home is the idea that if we're going to provide high quality patient care to each other, then I need assistance to do that. And having one of my members of my team, we can cross train and I can delegate tasks to them.
Yeah, absolutely. First off, like, how did you even get them to the point where they're actually interested in doing it at all?
Well, I mean, the best, it's the carrot and the stick, you know? So the carrot is these guys have become very proficient at this medical stuff. And that improves the look of our team. It gets us good mission sets. It improves the commander's view.
Yeah, of course.
And so when we're talking about using the stick, I basically like to put them up against each other.
Sure.
And almost competition. You know, we're all type A personalities.
Yeah.
So when you can kind of play the guys against each other, have them provide AARs for each other of their medical lanes, of their hands-on skills, of these kind of things, it's just going to push the whole group to improve. And normally when I do it, it's optional. I don't force anybody to do it. But as other team members see guys progressing and see guys just essentially crushing it, that actually pushes them to want to come do that. Because at the end of the day, the guys love to train. And, you know, dudes want to get out there and be professionals. They want to be excellent at all these different tasks. Especially when we're sitting around doing administrative stuff. It's super easy to throw a moulage on a guy, draw a unit of blood, and run out back and do a med lane.
Yeah, of course. You know, I mean, like you're saying, you know, guys want to not only be excellent at their jobs, right? But you want to accumulate tasks. And you also don't want to be the guy who doesn't know, right? So there's kind of that ego part of it as well. And it's great that you're like stabbing a stick into it so that, because it not only helps you, right? The selfish version of it, but, you know, ultimately it's going to help your patient outcome, right? If you have more than one person making decisions or capable of doing things, right? It's always self-aid, buddy aid, then you. Well, if they have to jump over two of the three to get to you to do anything, you're going to be sucking real quick.
Yeah, for sure. And especially when I'm running lanes with my guys, they just see how much more efficient patient care happens when they're competent. So, I mean, for example, you know, if I'm the guy sitting there prepping blood and doing the IV and pushing TXA, I'm not thinking about what's killing my patient right now. So it's really easy for me to offload that because I have trust in my guys and they've worked hard to get to where they are, where I don't even have to look. I'm like, hey, man, prep blood. And I know for a fact he's going to get 16-gauge IV. He's going to push TXA. He's going to prep the blood and he's going to administer the blood. And I don't have to oversee that. Of course, it's a trust but verify in stressful situations, but I know for a fact that guy knows how to do all those things.
No, that's perfect, because one thing that medics kind of along the same vein, you want to be excellent at your job, right? And you want to essentially do everything because I'm the medic, right? But you can't, right? And I'll say it again, you just can't, because everybody has a finite amount of decisions that you're capable of making. And if all you're thinking about is the next part of the March algorithm, right? Or, you know, each minutia, each step along the continuum of care, and you're not thinking of the overarching problems, you're going to get bit real quick.
Oh yeah, for sure. And it was really interesting when I first showed up. I was lucky enough to have some very solid mentorship. And that was one of the things that my senior really instilled into me is that, hey man, if you're the guy putting on the tourniquet, you're not thinking about what's killing your patient. And, tourniquet application is level 1 task. I can pull any of my guys, and I know for a fact that tourniquet's going to be on there good. So while I delegate that task out, and then I can go and start thinking about what's actually killing this guy.
Okay. So other than, team internal type stuff, I guess what are some of the other more tangible benefits you've gotten out of this?
In terms of training my guys?
Yeah, because you've trained your guys, how far have you been able to take it?
Well, a lot of different directions. So number one, operationally, like when we're out on a J set or something like that, I'm one guy. I can run one TRIC lane for partner force at a time. I can give one class at a time. And so I can take any one of my guys, push them out, and they can run their own lane unsupervised. So especially if our mission is to provide medical training to a partner force, then I'm confident that they can do that based on the training that they have done. And like I said earlier, not always dictated. Like they'll show up on their own time to do this training. But to build that confidence to where I can push them out like that, we've done this a lot there on Fort Carson. So we'll run down to the 4th ID guys, and those dudes, and provide TRIC training to them.
Right. No, that's perfect, and that gives you opportunity to kind of hone your craft. Because believe it or not, that's kind of our job, is to teach other people to do things, right? So it kind of gives you the opportunity to hone your craft before you punch out on mission.
Yeah, and it's a J set where the partner force speaks English. You know what I mean? And it's really awesome. We always like to talk about crawl, walk, run. And I view the run within a J set prep as actually going out there and teaching partner force at a high level, things that are outside of your MOS. So, we do our team internal TRIC training, both on the training calendar and in the mornings and things like that. Then I'll take those guys over to an adjacent unit like the 4th ID, and we'll do a march class there. I'll have them give parts of the class. I'll have them observe hands-on skills, and I'll have them run their own lanes without my supervision. And yeah.
No, that's perfect. That's perfect. So, I can only imagine the reputation within your company, battalion, et cetera, kind of grows as these guys are on it as far as medical things, right? So I imagine that also gets you probably better jobs to do downrange, right?
It really does. And I mean, especially if you look at medical training and medical capability, that's a huge risk mitigating factor. And, whenever we do these pre-deployment trainings and things like that, the commander's looking at all these lists, like what team is good at this, what team is good at this, what team is good at this. And just the ability to demonstrate an effective walking blood bank, that builds confidence in your commander's mind that when I put walking blood bank on my Kana, he knows that we can execute that because he's seen it. And I'm not different commanders do different things, but I mean, risk mitigation is always something we have to worry about.
Yeah,
and medical capability is something that definitely will lift your team within the company, battalion, group.
Yeah, absolutely. So, you're talking about when you came up in the ranks, right? You had really good mentors.
Mm-hmm.
Why were they good mentors?
A lot of different reasons. Number one, they pushed me all the time in every aspect of the job. So one of the best pieces of advice I got was not only be good at your job, but learn how to be the third best at every guy on your team. Because I'm never going to be a better demo guy than my demo guys. I'm not going to be a better comms guy than my comms guy. But I should be striving to be number 3 in all of those other aspects. And a lot of the dudes on my team have really taken that to heart. And I think that not only built a culture of cross-training within my specific team, but also is pushing these dudes to excel in areas outside their specified job.
Right. No, that's perfect. What about providers? Have you had good providers that, influenced you along the way?
Oh, for sure. So one thing, it's kind of a self-fulfilling prophecy to where once you start training your guys start asking you questions. And which is one of those things that's really pushed me in my practice. Not only the pull from the top or the push from my mentorship, my different mentors, but also almost the push from the dudes on the ground. Because once my guys, my non-medics, start asking me questions about like severe TBI, severe crush, different why we're using this drug and not this drug, it really pushes me to understand the actual pathophysiology of what I'm doing. When a lot of the things that we're trained on is very algorithmic. And as we're moving outside of that and moving towards more of an actual clinical decision-making process, understanding these things has been good for me and also good for my guys. So, every once in a while, these guys will stump me. They're asking good questions about high-level topics. And one thing that has been successful is I'll just take that guy and be like, we're going down to the battalion dock. And we'll walk down to the battalion shed and we'll ask the doctor. And not only does that build confidence in my guys, because they know that if I don't know the answer to a question, I'm going to go find it. And also when I take that guy to go talk to the doctor, it shows the doc that we are pushing this and builds his confidence in not only me as a provider, but also the dudes on my team. And then thirdly, the doctor's going to be able to explain this way better than I am, which builds my education and also builds my non-medics education as well.
Plus, you're also, how frequently is that doctor having to explain things to an engineer or weapons guy or things like that? Probably not very frequently. So you're probably also honing his craft as well.
Yeah, but it's fun though. It's even like when I'm going with my guys to sick call and they're using big medic words to providers that they don't know. They're like, "Are you a medic?" They're like, "No, I'm the junior Charlie." It's always fun. I like showing these guys off.
Yeah, of course. But it also, there's got to be a certain amount of humility as well, right? Because it's super easy to fall into the trap of, I'm the medic, I know everything, and if I don't know it, then it doesn't matter to anybody, right? Well, guys still are curious, right? And which is good, because that helps push them farther, and you're right, it helps push you farther in learning your craft better, because you don't want to look like an idiot. But it's definitely good to have that humility to not just say, it doesn't matter, to go hunt down, well, this is where we're going to go find that type of information, right?
Yeah, and on that, through the lens of cross-training, I have a ton of cheat sheets. I call it my dumb medic book that I carry around with me everywhere. And it's just a bunch of CPGs. It's all the stuff that you guys have on pfc.org. I just have it printed off, hard copy, in a book. So where one of the things that I've found success with, especially as we start cross-training into more like DCR, PFC type of stuff, is training my dudes how to use that book, how to use telemedicine. Because if I'm the guy laying there on that table, I need them to figure out, hey, here's the references that I have if we're in a non-communication environment. Here's a 3-inch 3-ring binder stacked top to bottom with CPGs. And I can just go step by step down the line. And obviously, ideally, we have the telemedicine script right there in the front. And they know how to pitch it to a doctor and then not only present a patient, but also understand what the doctor is saying to them.
Yeah. And obviously nobody wants to think about it, but believe it or not, medics get hurt too. It's not supposed to be that way, but it happens. It happens frequently, right? So, having your guys trained at the minimum of T-Tri-C, but hopefully T-Tri-C plus, that just is insurance for yourself.
Absolutely. And as we talk about like pushing towards our DCR and our PFC cross training, it forces these guys to actually get deeper into the weeds on what's happening inside the body, the actual pathophysiology. And it's really cool as they learn more about extended care, it actually makes their T-Tri-C better. So we always like to talk about how T-Tri-C is the base of everything that comes after it. But once you understand T-Tri-C and then you start learning about prolonged field care, it actually makes your T-Tri-C better.
Yeah, absolutely.
It's not, hey, I'm doing M and then I'm doing A and I'm doing things like, wait, what is an actual life threat right now? How do I define a life threat? And when the junior guys on your team understand that, it can make clinical decision-making processes or can make clinical decisions in a T-Tri-C lane. It's really cool to see. And it just gets me all excited.
Oh, yeah. Knowing not that prolonged field care is like the pinnacle of medicine, right? Which It is, but it's definitely going to make your TRIC a lot more efficient, because a lot of the things we do in TRIC is very fast, and sometimes we don't really think that hard about it, you know. But when you know the consequences of what you're doing, you're going to understand that you're going to be paying for this decision here in an hour, in 2 hours. So it gives you maybe that moment of pause, like, do I actually need to strike this guy, or maybe I can just position him? You know what I mean? Because you're not just handing him off in the next 20 minutes where you're like, yeah, it's that sucker's problem. You actually you're going to have to deal with this patient later on. So you're a little more thoughtful, I think.
Absolutely. I mean, it just comes down to day one stuff, like least invasive to most invasive, and just hammering down those basics. But one of the things in terms of building these guys' capability, and of course, I'm not going to get hurt on the medic, you know what I mean?
Yeah, of course.
But the idea of a mass cal, if there's too many patients for me to take care of by myself, which definition of a mass cal, right? I need to be able to push these dudes out to basically run independent lanes, essentially. Because I'm worried about triage, I'm worried about evacuation, I'm doing all this stuff. I'm not actually having any hands-on. So the way that I've always looked at mass cals is we're limited resources, right? That's the definition. But the three resources are, in my opinion, like Class 8 medical supply, medical personnel, and then time. So if I have 12 members on an ODA that are all 18 Delta minus level or 18 Delta plus level, we're going to provide much better care to all these casualties. It's where we can decrease personnel as a mass cal. So it's just, if I'm the only medically trained personnel or person on the ground and I have 3 casualties, like, I'm in trouble. But if we can increase our training level to where actual Class 8 resources or time are the things that are limiting us, that's going to make our team much better off.
Nice. So do you have any kind of organization as far as what you've trained? Like, did you just stop essentially at TRIC stuff, tourniquets, NPAs, needle Ds, or did you progress in any organized way?
Yeah, so in terms of progression, what I normally do is initially, crawl, walk, run every single year. You know what I mean? And I know that these guys are on top of their stuff, but me going all the way back through a March class is not only a refresher, they're going to pick up something new every time, and also provides them another example of what they're expected to provide to other units, even though that's not their job. So I always like to start with the why. Like, why are we doing this? And we talked about that today. And go through the actual, like, here's what we're going to do. Then we do it. So we do hands-on on all these skills, tourniquets, pressure bandages, all that kind of stuff. Move into dry lanes. So there's nothing wrong with the patient. And we're just going through our full trauma patient assessment, essentially, with nothing wrong with them. And then we start throwing in moulage. Then we start throwing in more scenarios.
Nice. So do you talk about, like, patient packaging?
Oh, absolutely. Patient packaging and handoffs is always, like I said, it's been drilled into me. And especially moving into different AORs, like hypothermia management, it's always been important. It's becoming even more important in some of the areas. Colorado's cold.
Yeah. So how about, like, med admin? Do you let them draw stuff up? Do you let them push it?
In terms of med admin, I'll put a really strong, it depends on that.
Sure.
So in terms of our SOPs for blood administration, if I tell you to prep blood, I tell you to get an IV, 2 grams TXA is counting. And so in terms of TXA, 100%. But in terms of anything that's going to affect my patient's mental status, I'm going to be in control of that if I'm able. Specifically because as I'm up there as the offensive coordinator, looking down, thinking, hey, what's going on with this patient? What's killing my guy? How am I prioritizing treatments? And my guys are going to town doing the treatments. If there's mental status is, most important vital sign. So I'm going to ensure that if I'm going to affect this guy's mental status, it's going to be me doing.
Okay, very good. What about, things like vital signs? Are you guys able to take vital signs for you?
Oh, absolutely.
Good. And document it?
Yeah. Well, it depends on their handwriting.
Oh, of course.
Yeah. But I mean, my dudes are taking vital signs. They're tracking it. You know, so my dudes are taking vital signs. They're writing it down, stuff like that. Once we get out of that initial like T-tri-C stuff, we like to talk about wake-up criteria in PFC, right? But if they have a basic understanding of what is high, what is low, they don't need to necessarily tell me exactly what's wrong with the patient, but they do need to recognize that something's wrong.
Right.
So if they recognize something's wrong, it's like, hey, Bryce, this is changing, this is happening. To where now I can include that into my decision-making process.
Yeah. So that's one thing I've seen guys when they make up a, wake-up criteria or whatever you want to call it, they'll say if his blood pressure goes down, if his heart rate goes up, right? Well, to you or I, like, yeah, that's shock. I want him to tell me. Well, to them, if his blood pressure, goes down by like 2 millimeters of mercury, to them, like, that's down, right? So, having some kind of like bandwidth of like, hey, if it changes outside of these types of ranges, come get me, right?
Yeah, and within this scenario, I'm not talking specifically about wake-up criteria. I'm talking about how my dudes understand what basic vital signs look like and what wrong looks like. And
but essentially those are the same, right?
Oh, absolutely. But just pushing it forward to where as we're working as a team and we're starting the absolute baby steps of training this guy's vital signs, the dudes understand what right looks like, because every time we do trauma lanes, it's on a live person, and they are taking vital signs. They are giving me what they have. And that's one of the things that I think has been very powerful. And when I train other units, I see a lot of finger drilling, shall we call it?
Of course. His blood pressure's 120 over 80.
And it's like,
really?
Well, I don't see a BP cuff on that guy. Yeah. So like, how do you know?
Oh, I felt his radials. That's
it's like, hey man. So when we're having these dudes actually understand what right feels like, because we're using live patients every single time. If we go into the SEM lab or we are doing other things, they know what is wrong. They know, hey, this isn't normal, and I need an adult.
Right. No, that's perfect.
Not to call myself an adult. I'm definitely, I probably need an adult. I need to call somebody else too.
Yeah, of course. But, I mean, face it, like, you've had the year of school, right? And X number of refreshers. Of anybody on the team, the medic is the one who has the experience to take in that information and then spit out a quasi answer, or at least a really good guess, right? So, that just feeds the machine, right? So, like you're saying, if you can have them do vital signs, if you can have them, basic tourniquets, put on a splint, know how to get a patient onto a litter, basic things, man, the ability for you to last the duration of this event is going to be exponential, because you're not having to make 400 decisions and then explain why you're doing it to somebody who has nothing to do with it. You're just going to be that much better off, Yeah, absolutely. Cool. So if you were giving any advice to a brand new medic who's coming in and he happens to know he's the only medic on the team, which, believe it or not, that happens, what would you give him?
Well, number one is you have to be good at your job. That's the absolute basis. And that means doing your reading, digging into these CPGs, seeking mentorship. Because like I've been saying, I've had solid mentorship both on my team at the battalion level and even from guys like you, Dennis. Listen to your podcast, But you need to be good at your job, and you need to make sure that your guys not only have confidence in you, because if they don't have confidence in your ability, they're not going to listen to what you have to say. And when you're teaching them, they're going to be sitting there on their computer. They're going to be building their PowerPoints. They're going to be doing admin stuff. And another thing about that is moving outside the team room to do your training is a very powerful tool, because, there's always people knocking on your door. There's always people needing something, run into, S1 and all that stuff. So if you can get the guys out of the team room, either to your local Mystic or even out back where it's harder to find you,
right.
That's going to increase the focus on your training, and it's just going to be better for everybody.
Perfect. I think that's a great place to close this out. Cool. You just ready for this to be done?
I am
All right.
very uncomfortable.
Well, thank you, Bryce, for coming on.
Hey, thanks, Dennis. Appreciate you.
That's it for today's podcast. Be sure to go to our website, www.prolongfieldcare.org. Find us on Facebook, YouTube, Instagram. Subscribe and stay on the bleeding edge of combat medicine. This is Dennis for the PFC Podcast. Out.
Boy, it's waiting there for you.